Good day, dear all, and welcome back to my channel. Today I'll be sharing with you some information on adrenal gland diseases. Managing diseases of the adrenal gland relies primarily on modulating the amount of hormones secreted and made available to the organ or systems intended. So firstly, I will describe the diseases of the adrenal medulla and adrenal cortex. Second, I'll explain the therapeutic interventions for adrenal gland disorders. Thirdly, I'll explain some counseling points for patient education about their treatment. What are adrenal glands? The adrenal glands are two small organs that sit on top of each kidney. On the right, it is triangular in shape. On the left, it is semilunar in shape. The adrenal glands make different types of hormones: cortisol, aldosterone, adrenaline, and noradrenaline. They also make hormones that your body uses to make sex hormones, estrogen and testosterone. All of these hormones do many important jobs, including turning food into energy and managing blood sugar levels, balancing salt and water, keeping blood pressure normal, responding to illness and stress, timing when and how fast a child develops sexually, and supports pregnancy. Adrenal cortex is richly vascularized and surrounded by a fibrous capsule. The yellowish outer cortex comprises 90% of adrenal weight. Central portion of the gland, which accounts only 10 to 20% of the gland by volume, is red-brown in color. A normal right adrenal gland is shown here, positioned between the liver and the kidney in the retroperitoneum. Note the amount of adipose tissue here. The adrenal glands are composed of two functionally separate layers, the adrenal cortex and the adrenal medulla. The adrenal cortex has three distinct zones, and each zone has its own regulation and secretory products. These three zones, from external to internal, are the zona glomerulosa, zona fasciculata, and the zona reticularis. Adrenal medulla are cells within the medulla and are modified postganglionic sympathetic neurons that form synapses with preganglionic sympathetic nerve fibers. And they secrete catecholamines, epinephrine and norepinephrine. Adrenal gland disorders occur when the adrenal glands produce too much or too little of these hormones. Diseases of the adrenal cortex affect three different hormones: cortisol, which helps to regulate the body's response to stress; aldosterone, which is part of a hormonal family or axis and which works together in the renin-angiotensin system to regulate water and salt; and sex hormones androgen, which help start puberty and play a role in reproductive health and body development. Diseases of the adrenal medulla affects the secretion of catecholamines involved in the fight or flight response. The cause of adrenal gland disorders depends on the type of disorder that a patient has. Causes can include medicines, such as steroids, a problem in another gland, such as the pituitary gland. The pituitary gland releases hormones that signal for adrenal glands to work. Changes in genes or mutations. These changes can cause the adrenal glands to make too much or too little of one or more hormones. Other causes include tuberculosis or other fungal infections or cytomegalovirus infections. Several clinical conditions can result from abnormalities of the adrenal hormones. One example of a disease of the adrenal medulla is PHEOCHROMOCYTOMA, where chromaffin cells, i.e. cells that store epinephrine secretory vesicles, contain rare catecholamine-secreting tumors that arise from the chromaffin cells. Adrenal insufficiency occurs when there is inadequate production of glucocorticoids, mineralocorticoids, and adrenal androgens, while cortisol-producing tumors cause a condition called Cushing's syndrome and congenital adrenal hyperplasia, which refers to a group of genetic disorders that affect the adrenal glands. Adrenal gland disorders are typically diagnosed using hormones as the biomarkers. Doctors might simply want to get blood or urine tests and scan the organ again later. A tumor may need to be removed if blood or urine tests show it is making extra hormones, or if it is larger than 2 inches across, or when the doctor thinks it might be cancerous. Adrenal insufficiency are divided into 2 general groups: primary adrenal insufficiency, or Addison's disease, due to primary hypofunction of the adrenal cortex, or secondary adrenal insufficiency, due to adrenocortical failure secondary to deficient secretion of ACTH from the pituitary gland. Addison's disease results from progressive destruction of adrenal cortex. At least 90% of the gland is destroyed before signs of insufficiency appear. The major signs and symptoms include asthenia, which are weaknesses, tiredness, fatigue, anorexia, gastrointestinal symptoms, nausea and vomiting. For its management, in the hospital, fluid lost is replaced. If there is reported decrease in blood pressure or patient reports of dizziness, then the BP is monitored closely. The patient is protected from any fall. Accurate input and output, including food intake, must be monitored. The specific gravity of urine as well as daily weight are taken. Upon discharge, the patients are educated on the importance of follow-up visits, how they must protect from stressful situations, and why it is important for them to have 5 to 6 small meals throughout the day. In the event that the patient is admitted with acute Addisonian crisis, the patient is given glucocorticoid replacement where cortisol 100 mg every 6 hours for 24 hours is administered. Once stable, the dose is reduced to 50 mg every 6 hours. The dose is then tapered to maintenance therapy by day 4 or 5 and a mineralocorticoid added if required. If complications persist or occur, the dose is increased to 200 to 400 mg per day. As a general rule, the volume depleted, dehydration, and hypoglycemia are all corrected with IV saline and glucose. The patient is evaluated and treated for infections and other precipitating factors. Patients usually require lifelong replacement therapy with glucocorticoid and mineralocorticoid. Cortisol, available as tablet, would be the first choice, and a maintenance dose of 15 to 30 mg per day is given in 2 divided doses in the morning and in the evening. Alternatively, cortisone acetate is given as a dose of 37.5 mg per day and is absorbed rapidly from the GIT, converted in the liver to cortisol. Synthetic steroids can also be administered, either as prednisolone, 5 mg of prednisolone tablet, or fludrocortisone, used for mineralocorticoid therapy. Once or twice daily tablets of hydrocortisone, a steroid hormone, is given. If needed, aldosterone can be replaced with a fludrocortisone acetate, which is taken orally once a day. Patients need to be advised so they do not abruptly stop taking the medication. This can result in death. They should also wear a medic alert bracelet at all times. They can carry an emergency kit for administering 100 mg of parenteral hydrocortisone during times of extreme stress, such as maybe at school or at work. Cushing's syndrome is a condition resulting from chronic exposure to excess glucocorticoids. Etiologies include chronic glucocorticoid intake, increased adrenal secretion of cortisol, or increased pituitary or ectopic secretion of ACTH. Typical features include central obesity, thin and bruisable skin, secondary hypertension, hyperglycemia, and muscle weakness. Diagnosis is by urinary and/or salivary cortisol testing, along with a low-dose dexamethasone suppression test. This slide further explains the signs and symptoms typically present in Cushing's syndrome. These signs and symptoms are important so that the early manifestations are not missed. The treatment depends on the cause, and often the removal of the adrenal gland solves the problems. Adrenocortical hormones are given as substitute. It is important to prevent an injury and infection in these patients. The weight as well as vital signs must be monitored, and the laboratory findings, electrolytes, glucose levels are constantly monitored. Cushing's syndrome, due to an adrenal tumor, is treated by surgical removal of the tumor, which often includes removal of the gland as well. The major role for surgery in this patient population occurs with primary adrenal hypercorticolism, either due to adenoma or to adrenal carcinoma. If surgery is not possible, medications can be used to suppress the secretion of cortisol. Post-adrenalectomy patients require close monitoring of electrolytes, especially potassium. Glucocorticoid replacement therapy is usually required until the other adrenal gland recovers from surgery. Glucocorticoid therapy may be required for 9 to 12 months. If both the glands were removed, then lifelong glucocorticoid treatment is required. Adrenocorticoids are used as hormonal replacement therapy, and they are available as oral IM/IV inhalation, intra-articular or topical preparations. However, they interfere with the release of important factors in the normal inflammatory and immune responses. They also increase fat and glucose formation and promote protein catabolism. Examples of adrenocorticoids are glucocorticoids, which are dexamethasone, methylprednisolone, or hydrocortisone, or mineralocorticoids like fludrocortisone. Side effects of adrenocorticoids include Cushingoid appearance, hypertension, hyperglycemia, frequent mood changes, GI irritation and ulcer formation, cataracts and glaucoma, hypokalemia, leukopenia, osteoporosis, masculinization in females. Management of exogenous hypercortisolism involves optimization of glucocorticoid dose and route. Glucocorticoid sparing agents are used to minimize the glucocorticoid dose. Adjunctive treatments aim to reduce the effect of glucocorticoid treatment. Other drugs that may be considered include biphosphonates in cases of osteoporosis or fractures, prophylactic treatment with H2 antagonists. When medications known to cause gastric irritation cannot be avoided, zoster immunoglobulin for immunosuppressed children who are in contact with varicella, inhaled steroid treatment, intranasal glucocorticoid, and steroid ointments are given. In patients with endogenous Cushing's syndrome, the same medications are used in inpatient and outpatient care, with the exception of etomidate, which is intravenously administered in very sick inpatients. It is important to advise patients to look out for early warning signs and to protect themselves from an infection. They should also be encouraged to speak about their feelings because of the new changes in their image and sex drive. They should try as far as possible to minimize stress in their environment on a day-to-day basis, as well as make slight modification to their diet. A PHEOCHROMOCYTOMA is a rare, usually non-cancerous or benign tumor that develops in an adrenal gland. In patients with PHEOCHROMOCYTOMA, the tumor releases hormones that may cause high blood pressure, headache, sweating, and symptoms of a panic attack. If a PHEOCHROMOCYTOMA isn't treated, severe life-threatening damage to other systems can occur. Surgery to remove a PHEOCHROMOCYTOMA usually returns blood pressure to normal. The classical signs and symptoms of PHEOCHROMOCYTOMA involves four characteristics: headaches, palpitations, diaphoresis, which is excessive sweating, and severe hypertension. There are two methods of diagnostic testing. First, the plasma methamphetamine testing, which is highly sensitive as well as specific. Otherwise, a 24-hour urinary collection for catecholamines and metaphrines, which is slightly less sensitive but highly specific. Once a pheochromocytoma is diagnosed, all patients will usually be advised to undergo a resection, following appropriate medical preparation. Agents known to provoke a pheochromocytoma paroxysm, such as beta-adrenergic blocker, glucagon, histamine, metoclopramide, high-dose corticosteroids, should be avoided. Cardiovascular and hemodynamic variables must be monitored closely. Continuous measurement of intra-arterial pressure and heart rhythm is required. In the setting of congestive heart failure or decreased cardiac reserve, monitoring of pulmonary capillary wedge pressure is indicated. After the procedure, the BP of the patients in upright and horizontal positions are monitored. IVFs are administered, and if bilateral adrenalectomy was performed, the patients will be instructed on the maintenance doses of steroids, and they should also take antihypertensives and monitor their BP until stable. These are some of my references. And with that, I've come to the end of my talk. Thank you very much indeed for your kind attention. If you have any questions, do place them in the comment boxes and I'll try and answer them as soon as possible. If this video has helped you, do give it a thumbs up and subscribe so you will know when my next video is up.